Welcome to the Clinical Consultation Network, everybody. Thank you for being here today. We appreciate having you every Tuesday at 1:30 p.m. Central Time. We just take an hour, 55 minutes essentially, to go over a case. And we've got a great case today that our behavior analyst from the Harold Jordan Center, Grace McDonald, is going to present. She has with her Josephine Richard, so we'll start out here in just a minute getting some introductions from them. And so one of the things I want to make sure people are aware of, though, as we move forward, there are a lot of resources at the regional offices. We had, a few weeks ago, we had a presentation that was that David Taylor and I made about sexuality. And I'd just like you to know that there are resources within our regional office who may be able to help you with some of these considerations that you may be making about the persons you're supporting. And so I encourage you to reach out for those folks. Stephen Bell, in particular, has made himself available for that. And so I would encourage you to get in contact with him if you're in West Tennessee and see if he can help you with any of those situations you may be facing. Likewise, I wanted to mention also that we have ACES training available for people. I'm not sure we have anybody currently in East Tennessee who can provide that, but if you'll let us know if anybody's interested in the training regarding adverse childhood experiences. And so this is something that has to do with our population because many of them have had adverse childhood experiences. I've mentioned many times that people with IDD, that 70% of people with IDD, and I think that may be a low number, but that's what Laura Validarian is reporting. 70% showed up as having an at least one adverse childhood experience. And so this can have a great impact on a person's behavior and their manner of dealing with the world from that point forward. So it's really important to understand a lot of this. And one of the things that if a person has been neglected or abused, a lot of times it changes the way their brain functions. And particularly, a while back, when you're talking about people with autism spectrum disorder, and somebody had the impression that people with autism spectrum disorder couldn't experience that type of trauma. But there can be changes to the brain and the way the person reacts to the whole world that will change as a result of that. And so that can be very valuable information. I encourage you, if you need to get connected with this information about adverse childhood experiences, I think the training is about a 3-hour training, or it can be even briefer. It can be just a 30-minute training that you can get, but it can really be something that's helpful. If you need to get that type of training, let us know about it, and we will see if we can arrange for someone to come out and do that for you. So that's that. Now, to our case today, we have Grace McDonald, a board-certified behavior analyst working at the Harold Jordan Center. And Grace, before we get into the case, can you just tell us a little bit about yourself, maybe where you came from? Did you ever watch that movie Forrest Gump? He said, shoes tell you a lot about a person, where they come from, where they've been, where they're going, that type of thing. Can you tell us a little bit about where you've been, where you're going?
I am originally from Georgia. I went to MTSU for grad school. Did some research at a medical lab right after grad school. Then eventually just ended up back in Nashville. Worked for an in-home behavior analysis company for 5 to 6 years. And in February, I came to HJC, and I love it.
We couldn't have been more happy that you came to HJC. And you should just from Georgia. Where in Georgia are you from?
Near Atlanta. I don't know, Marietta, Kennesaw, close to there.
Yeah. Well, you're right in Braves country right now. I mean, if you were still there, but you're not still there. But, okay, so any kind of interesting facts about you? You don't have to share anything you want to share, but any kind of hobbies or anything like that that you're interested in?
I can play football pretty well. I like to co-ed sports, so work out, sports, like to read.
Okay. You say you're a college sportsman?
No, I said I like to play sports.
You like to play them?
I can throw football pretty well.
Okay. Wow. All right. That's good. That's good. And Josephine, we have you on the phone. Tell us a little bit about yourself.
My name is Josephine Richard. Born in Senegal, come here in 87. And this was before I come here, I was working in the hospital. I just love to help people. That pushed me on this field. When I come in, when I find this job, I was really happy because it's the kind of people you feel you're going to help people. And I work in Clover Bottom like almost 19 years, and I transferred to here. I always love to be with people I can help, you know. And when I come here, yeah.
Now, I heard you say you're from Senegal.
Yes, from Senegal. West Africa, Senegal.
Yeah. Is that right? That's right below Mauritania, right? You're Mauritania or Morocco or?
No, it's west. I'm not really far from here. It's the west. If we border with Mali, if you know the
yeah. Right.
And I just love, yeah. I just love to be with people, to help people. Yeah. When I come here, I was saying I'm gonna follow my career. Man, we got 5 kids. And I couldn't make it. My husband go finish. Me, I can't do make it because we have to take care of them, all the house, everything. I just end up like this. I don't know. Yes.
Oh my goodness. You got your hands full between work and
yes,
home.
I am. And when I go to school, I couldn't do it.
Well, you're great. I'm really glad to have you on here today so that you can hear a little bit from what Grace is going to tell us about. So thank you for being here. So Grace, with that, I'll let you kind of take off from there and tell us a little bit about this case you want to discuss today.
All right. So some of you might remember someone we spoke about, Jill, who had issues getting her to comply with the swallow study. So this is a follow-up on her, and I wrote poor Miss Josephine into helping me with this today because she is so good with Jill. So Jill's 19-year-old female. She has a diagnosis of autism as well as intellectual disability, Lennox-Gastaut, and also she uses a thickener in her liquid due to dysphagia. Before coming to the Harold Jordan Center, she lived and went to school at the same facility. While there, she engaged in behaviors that did pose a risk for her safety as well as others. So she would approach strangers in the community. She would elope, disrobe, and engage in eliminating behaviors, resist transitions, inappropriate contact with others, physical aggression, sexual behaviors. She tried to jump out of a van while it was in motion at one point. And based on school records, she did get some services while at the facility where she was living. However, due to some increased agitation during this time, she went to a doctor's appointment, and due to increased agitation there, she was hospitalized inpatient for approximately 2 months, and we got her after her hospitalization there. She does, Lennox-Gastaut is definitely something that is a childhood onset form of epilepsy. It's very severe. It's difficult to treat. So it can be difficult at times to say what is autism, what is maybe intellectual disability, is she having a seizure right now. Grandma has said that her grandmother has said that, it might look like she's not complying, she's not listening, she's refusing to do what you ask her to, but she might be having a seizure during that time. She might lean against the wall, turn her head, stare into the distance. So those are all things that, as practitioners, we have to be aware of to try to differentiate between medical condition and what is behavioral. Ashley just joined us. So you want me to start? She got in here. Oh, there she is.
All right. Well, let me let you go ahead and continue with the case, then we'll come back to Ashley in a minute, okay?
Okay. So there's some history on her. Ms. Josephine, do you have anything you want to add so far? I'm going to talk about her behaviors here in a second.
Yeah, the way you say it, when she came, there was a lot of behavior with her, And now the longer we was staying with her, we study what she like and what she don't like. Now we kind of pretty much control the way she was when she come over here. It was loud on her.
Yeah, so when she's here at HJC, all behaviors have decreased. But when she first came, there was disrobing. She'd take her clothes off in the hallway. It wouldn't matter who was around. It could pose a safety risk to her, safety risk to others. Eliminating behavior, she would fecal smear. She would void in areas other than the toilet. Physical aggression, she'd push, charge with her body, hit, pull hair, scratch. I don't think my arm will ever be the same. It's so scratched up. She had negative transition. She would drop to the ground. So, at times, if you don't want to transition between classrooms at HJC, that's fine. But there was a time when we were at Vanderbilt and she dropped where the cars were driving. So, the safety issue at times. Eloping, leaving without permission, and then refusal, just not following through when demands are placed. And there are times where she's an adult, clearly she doesn't have to follow all demands, but there are some that if it's medication and seizure medication, you really need to take your seizure medication. Really need to follow through on walking across the street at Vanderbilt. So those are some behaviors that we saw. And another one that is interesting was that she walked a significant amount when she first arrived at HJC. It was as if she could not sit still. So that's something we definitely had to work on as well. And I think maybe you even saw that, Bruce, when you came here one time.
Yeah, I think that's why when I kind of wrote a little bit of an intro for this, I used that word stick-to-itiveness, which might have a little bit different meaning in her case than it does in the example that I gave of Sam Gardner, but I think it's a concept, kind of a colloquial concept that we are working with, trying to get people to kind of stick with things a little bit more, stay with it, engage, be more engaged, and so that's where I saw something that I thought was a difficult thing with her when she first came. And so that's good. And this was, now, remembering, Grace, when you talk about these different behaviors that she's engaging in, what was the function behind these behaviors? What did you assess as the function?
It would depend. Escape, attention, and tangible fun.
Okay.
Based on it did not seem that anything was sensory, but it definitely looked like escape, attention, and tangible. And based on the graph and the direction of the data, it appears that those were hypothesized functions were accurate.
Okay. Thank you for that.
So, do you want me to talk about some of the replacement behaviors that we tried to replace these inappropriate behaviors with?
Yeah, that'd be great.
Okay, so one thing I wanted to increase was her attention. So instead of I want to walk around the building all day, I'm going to look at something for 2 seconds, which isn't very functional. How are we going to have her sit down for an extended period of time? So we put activities all over the building because she would walk all over the building. And so then in each room, she could have access to different activities she liked, and then we've narrowed down based on that some of her preferences. She loves fingernail polish. She's like a typical teenage girl. She likes Facebook, fingernail polish, YouTube, magazines, fashion. So I wanted her to be able to expand the amount of time she would sit and engage in appropriate behaviors. We'd start small, and then since then she's worked up to, I think, maybe 2 or 3 hours at a time being able to sit in her room. I mean, we don't force her to stay in her room, but she will choose, I think, to sit with her tablet.
When she got a tablet, she'll stay in her room. When she got a tablet, she'll stay in her room, maybe 1 hour, 2 hours, and later maybe if it dies, she's gonna come in and hand it to you for you to charge it, or maybe if we don't have another one, we give an option, like we give a magazine, or we bring a puzzle, we do it together and make it a little bit sick, or we play a ball in the hallway.
So you're talking about, Justin, you're talking about interactive things that you're doing with her. So go ahead.
To make her drawing engage like a kind of behavior, we're trying to make her occupied and to bring in some activity like magazine. If she don't want it, we play ball, or we bring the puzzle, we do it together. And sometimes when the tablet is dead, because we have to wait to charge it. I mean, if she keep on going, you have to find something to make her focus on that.
Well, that's great. You know, one of the things I'll say to that, so years ago when I first started in this field, this is like one of the first people I think that came to a place where I was working to do some training. His name was Lee Graver, and he came there, and one of the things that he consistently talked about was putting a do with a don't. So essentially, where it is that you're trying to deal with a troublesome behavior of some kind, that where you can give the person something to do, active to engage in, that is one of the best ways of trying to intervene more effectively. And, you know, so if you're constantly finding yourself in a position, hey, don't do this, don't do that, don't do this, giving them something to do as a replacement behavior essentially is a very, very important aspect of that.
Yeah, which that was a great segue into two things. One, me giving some of her staff so much praise. And I think as practitioners, we can come up with plans all day, but if we don't have like the staff to work with them, the staff who just is really invested like Ms. Josephine, then the plans might not work well.
Oh, hey, while you said that, why don't you just mention one other thing that Lee Graver said? Because it was, what you just said is so close to what he said. Now, this is old technology because we don't use turntables anymore to play records. But back in that day, it was very relevant. And he would talk about, like, if you didn't have the diamond needle that touched the record, then it really doesn't matter how good the rest of the system is, you're not going to get very good music out of it. And so his analogy was that basically that diamond needle was the direct support professional that was working with that person. So what you said basically was a restatement of what Lee Graver was saying all those years ago.
Oh, you know, I just try to copy the best, right? So one thing that I said that she really seems to like attention. So replacement behavior we worked on was seeking attention appropriately. It appears that she can be aggressive when trying to be affectionate. So, or if I want you to do something, maybe I'm aggressive towards you. If I want your attention, I'm going to fecal smear. So instead of that, we worked on ways to appropriately engage with others and seek attention. So meeting them somewhere, sitting down next to the person. How do we appropriately hug a person? And appropriately, Ashley just reminded me appropriate knocking. She will bang on doors throughout the building. Like I don't even understand how she feels feeling in her hands to bang so hard. And appropriate knocking. Well, if she appropriately knocks on the door, then we'll answer the door for you. So just throughout the day, really reinforcing the appropriate attention seeking. We have a speech therapist who has started working with her, so that's another way for her to appropriately seek attention. I gave some cards for her to use as well, but the speech therapist, since that is more her scope of practice, has been really nice to have.
Yeah. So how long ago did the speech person start helping?
About maybe 2 months. We had one, and then we switched to a different one. So she's been really great to work with, and she's coming on the weekend to work with Jill. It's been really nice.
Yeah, it sounds like a good collaborative effort. Now, when you said you were working with her on these things, how did were you more or less taking natural opportunities throughout the day, or was there a period of practice, or how did you work with that?
Natural. She moves so much, and she has a 2-to-1 staff ratio that especially at the beginning, that, you know, she could have 2-to-1 staff, but then she's walking through the hallways and there's 3 other staff members, and if she approaches one and tries to get up in your space, you know, that's my personal space, you say boundaries, you can put your hand out to show her where she needs to be. If she knocks on the door appropriately, we can answer the door. So just throughout the day, I don't know. I mean, I could have used to sit down, do street trials, things like that. It seems like in this environment with her, the natural was the best way to go.
Well, yeah, and so in this case, you achieved some success with doing it in the way that you've done it. So we can't argue with success, right?
Yeah.
well, in these circumstances where she might come up and approach someone without doing those things, basically that was your redirection option. You would redirect her to do the response that you had been coaching her on, and then you would provide the reinforcement. Is that
if we could. Yes.
All right. Very good. Very good. I'm just clarifying things for myself.
I appreciate it. So escape was another function we looked at, and so she would engage in aggression. She would walk away when she didn't want something to occur. So we looked at using a tablet with her. So if I don't want to be in the hallway and I want to go on a van ride, well, we're going to have to communicate through the tablet. And, I'll push the button and the tablet can talk to you, and then you can push the button and the tablet can talk to me, and I know what you want to do. Or she could use a break card. Go ahead. Ms. Josephine, do you have anything you wanted to say about that? Either of those things?
Yeah, really, she was really working with what's her name?
Miss Rita?
Miss Rita, the way she was telling her, every time, sometimes, even you give a magazine, she don't want it, or she's going to push that, tell you she want to go, because she got to go on it. And sometimes sometime in the 9 o'clock or 8 o'clock, she pushes want to go. We got to say, no, we got a program to follow. And we bring the magazine or puzzle, and when she finishes to do it, we tell her, wait, 10 o'clock is the best time to go. This time is too early. Let's finish the program first. And she's going to sit and she's going to do the magazine. You give the puzzle. She's going to do the puzzle with you guys, and later you tell her, okay, now it's time to go. Or you give her the tablet, tell her to choose what she wants, and she's still going to push go.
So that sounds like fake training, right, Ms. Josephine?
Yes.
Say that again, Grace. I'm sorry.
Wait, training. We're going to learn to wait. You can't have what you want.
So, and that's a really important need for her to be able to have that skill of being able to delay something. And it sounds like, again, you were using some sort of an interim activity to help her learn that or to bridge the gap.
Yes, they're excellent at doing that with her.
Yeah, I really, the way when she came, the way she was, and later we learned, and she learned the way we want. Every time you want something, you have it right away. You got some stuff to do, and you gotta have it. And she was pretty good. She was following. Sometimes when she wants something, you need to wait. Or you remember when she get up, say, let's go breakfast. She get up and start running. We say, no, we gotta walk. Because it's not only here she's gonna be. Sometimes maybe when she go to the community, she's gonna be going out. You can be letting her running, and you be running behind. And she follow. She walks to the dining room. When we coming back, she's gonna walk. And we tell her, we gotta go. You use the bathroom. She go to the bathroom, use it, and reach her tissue, and you give it her. When she finish, you make her. She come and stand up in the sink. You put soap, and she wash her hands.
So you worked on a bathroom.
She can, yeah. I was really happy for her, the way when we got her, the way she was, and now she's really understand when we telling her to do something, she do it. Sometimes it takes a time for her, because I understand. It takes a time, and she really do it. Yeah.
She does, and another one of our replacement behaviors was appropriate engagement with tangibles. It sounds like you think that she's really engaging appropriately with books and magazines and balls. And what do you think her favorite activities and tangibles are?
Her favorite activity, she loves what's her name? I know she loves the tablet for Facebook and YouTube. Man, when it's working for the puzzle, she really sit down and do the puzzle.
Okay, another thing we were working on is appropriate tangible requests. Would you say that things like pointing to items, guiding people to items, maybe using her tablet to show you, would you say that she's also engaging appropriately and asking you for things and showing you what she wants and letting you know?
Yeah, like yesterday, second shift, I worked with her. And sometimes when she, I don't know, she tears up the magazine. I remember one time I bring her some magazine, and later she was tearing. I said, you know what? I'm not going to bring you no more magazines. She sit down over there, she looked at me, I said, yeah, and I mean, I'm not going to bring you no magazine. Why you tear up the magazine? She put it down. I was so happy. She put down the magazine. She didn't tear it up no more. And the next day I was telling her, you remember what I tell you? When you tear the magazine, we don't want to bring no more magazine here because you don't want it. You know, she put the magazine down. Yesterday, we didn't bring the magazine out. She got a tablet. When the tablet dead and she going, because we put sometimes her activity on one room. We went there. She want to go there. I said, okay, let's go. You choose what you want, and it's going to be one item. And we don't want to tear the magazine. She went on her bag. She took all her pictures. She bring it. She go back in the bed, lay down, and start looking at her pictures. Yeah, she stayed there more than like 1 hour.
So I think to sum it all up with the replacement behaviors, that basically the functions of the behavior were escape, attention, and tangible. So we look for replacement behavior for appropriately gaining attention, appropriately escaping tasks, and then appropriate engagement with tangibles, as well as the appropriate requesting of tangibles, all of which seem to have, based on the data, and I sent Michelle some graphs, her data has a pretty consistent decreasing trend. So it appears, based on data, that the behavior is decreasing and that the replacement behaviors are working.
Are we able to show this data?
The one thing that we still struggle with some is her physical aggression. But that also seems to correlate with how she feels physically. So she's been sick. She had H. pylori. We seem to see a spike in H. pylori. I believe that was in April. Ms. Josephine has something to say.
If she don't sleep when you come in, you see it on her. She really aggressive from that too. If she don't have enough rest. Like sometimes she stay 2-3 days, she don't sleep enough. When we come back, we find some issue on her. She wanna hit somebody. She always physical aggression.
Yeah, so it appears that the physical aggression, that's the blue that you can see on the screen, that fluctuates. And she also, you see a spike, I think it's going to be in August and September. She had a UTI. She began to be treated for a UTI at the very beginning. She had crystals in her urine, so at the very beginning of September. So August, there's a spike. September, it starts to go down a little bit. She gets her antibiotics. And then by October, it's significantly decreased.
So you really don't have a good way of differentiating what might be, you were not really mentioning seizure disorder as a possible contributing factor to the aggression.
We talked about that. We talked about that with our psychiatrist because I did a little research and it mentioned sleep and their seizures going together and that possibly being what could also increase behavior, and he confirms that. However, trying to get her into have this studied and like, hey, is she having those seizures at nighttime would be very difficult to get her to sit still and keep anything on her head.
Okay, because I know that has been an issue the last time that we spoke. It does look like your aggression's on an overall decreasing trend, but you're still having in excess of a couple of those per day, it looks like.
Yeah, we are.
And what the thing I might try to do with these data going forward is if you have the hypothesis that this has something to do with physical discomfort, is see if there's a way to figure out how that's operating. If there's any other way to tell that you might have physical discomfort at those times, that might be something that would help you confirm your hypothesis. So,
I have approached the nursing staff if she is engaging in aggression that is atypical. I have approached the nursing staff and said, hey, can we please, is there anything we can do to see, is there a fever, is there, is it menstruation, what is happening that could increase this behavior?
And so what I might suggest you do with that is, to the extent that there's something identified or that there's some treatment provided, to kind of connect those two dots so that you're able to say, okay, well, yes, in this case where aggression occurred, it did appear as if this was, a possible cause for it, and then in other circumstances where it wasn't, and that way you kind of get a little bit of an idea of what proportion of that's occurring. Now, let me ask one other question here about, were there any kind of medication changes or anything else going on during this period that you've been working with?
She took, during September, there was some medication change, so they added medications for crystals in her urine, and then they put her on something on 9/12, which she has consistently stayed on since then. She did take antibiotics for H. pylori as well, but to my knowledge, she was taking a medication that was causing her appears to be causing her to sleep during the day, and that was fully taken away, or it was fully taken away. So, and we also thought that might increase her aggression as well.
So that was a sleep medication? Is that what or was it a medication given for something else that you thought had a side effect of sleep?
It was in the same group as Benadryl, the medication she was taking.
Hey, Bruce, it's Victor.
Oh,
hey, Victor.
Hey, just as we're talking about her medicine, she came in to us from Vanderbilt on 7 psychotropic medications, and one of them was an antipsychotic, and we felt that some of her pacing at the beginning might have been secondary to akathisia from the risperidone. It's just hard to differentiate what was curiosity, looking at a new unit, new places, new doors to bang on, and a medication side effect. But we were able to decrease your psychotropic medication from 7 medications to being discharged on 2, one of which is melatonin. So we kept the melatonin, even though she's not sleeping well. It may be helping her sleep a little better than what she would be sleeping all without it. And we kept Celexa for 2 reasons. One is she did have some OCD-like behaviors, and the second reason is for treatment of premenstrual dysphoria. And just concerning her seizure disorder, she has Lennox-Gastaut disorder, which is historically really hard to treat. One of the things about Lennox-Gastaut is your seizures are often brought on at the beginning of sleep, and they could be subclinical. So a lot of her sleep problems could be secondary to her seizure disorder. But her treatment of her seizure disorder at Vanderbilt was excellent. I mean, they ended up, basically she has no seizures anymore that we can actually see. Doesn't mean there's not the one to sleep. But anyway, that was just my 2 cents about the medication part.
Yeah, they did mention here about Lennox-Gastaut syndrome that there can be non-convulsive spells of epilepsy. And so, there can be some that are kind of under the radar, I suppose, to the naked eye. But yes, you can still be getting some seizure activity or electrical activity that's kind of causing her to respond in the way that she is. You mentioned also akathisia, which is a term that is probably good to explain just a little bit for our group. So you want to explain that a little bit?
Yeah, sure. Antipsychotic medications she was on risperidone, which is an antipsychotic, can cause a feeling of restlessness, and that's called akathisia, or akathisia, and it's spelled a few different ways and pronounced a few different ways. But it's just this need to move, kind of like some people describe as, ants in your pants. And when she first came in, she was just wandering everywhere, and we couldn't tell if it was really a side effect or part of her curiosity. But the medicine wasn't helping her anyway, so it was a pretty easy decision to slowly discontinue it.
That was Dr. Cheatham's number one thing on Cheatham's checklist, blame the meds. And of course, we don't know that it was after different circumstances. It certainly can be. And, we're concerned about activity level, and not everybody that takes an antipsychotic medication experiences akathisia, but some do. And where they do, it may, start to look a lot like the very symptoms and behaviors that you're concerned about. So that's a good move. Well, all right. Grace, we've got Ashley there. I don't want to leave Ashley out. Ashley, do you have something you want to add about this case? First, before you do, I need you to tell us just a little bit about yourself, because I do that with our guests. So tell us a little bit about yourself, and then if you have something else, answer it, or if you don't, that's fine.
Okay. I'm originally from Louisiana. I moved to Nashville last year in September. I've been at the Jordan Center for just over a year. I really enjoy what I do. I really enjoy working with the clients that we work with. Particular client has been one who is kind of a favorite of mine, just because of seeing her progress and her growth. And so she has really come a long way, and so we would get very excited over, little improvements, or the first time when she would start appropriately knocking on windows, letting us know she wanted to go outside, and then she would get to go outside. That kind of became a way she can communicate with us. And so just seeing the growth that she's made and the relationship she's formed with our staff has been very rewarding.
Yeah, just thinking about that moment for you really gets me excited to even think about the case. Just to think, okay, now we see her independently do this thing that previously was kind of very frenetic and kind of out there. And being able to stick to it enough to know that there's, you're gonna help her out. You're gonna do something for her under those circumstances. I think there's a lot of patience that comes from that. A lot of stick-to-itiveness, as I was calling it earlier. Now, you said you're from Louisiana. Are you from Baton Rouge, perhaps, that area?
I'm actually from Alexandria. It's about 2 hours north of Baton Rouge.
Okay. Are you an LSU fan? I probably shouldn't have brought this up because I probably have no fans on the phone too.
Yes, I do sometimes watch the games. I'm not like a diehard fan, but I am, I do support LSU.
I'm not gonna go any further with it because I don't want to bring insult. Well, I don't want to bring any further insult to the Alabama fans out there. So I'm just with it. Well, all right. So, Grace, coming back over to you. What else do you want to tell us about this case?
I would say that based on data, based on observation, and, based on it's observation, but how she seems to have more confidence in herself, which is totally, there's no data to support that, but she does. I'm feeling very excited to transition her out into the community on the 18th of this month. We've been had some great staff to work with, to train. I feel like she's going to have a lot of success if we have the right support in the community. I've already spoken to one BA in the community who I went to school with, and I think there could be a lot of success with that BA if they ended up going together. I'm very pleased, and I'm very very happy with the staff I have to work with, and I'm very thankful Ms. Josephine was willing to come talk with us because she's the one, along with other staff members, who are on the front line. So overall, I think it's been a great success story overall.
You kind of hit on using the word confidence there, and I understand why, because as a behavior analyst, you're more clinical, you're looking at behavior. And yet, at the same time, when you put a word like that on it, I think it kind of translates to what it is trying to accomplish. And, I do think that confidence can be applied to that. It's a confidence that there's reinforcement out there in people. If I can do this thing, and and then being able to have confidence enough that it's coming. If I do respond in the way that I need to. And so that you've been able to communicate that, I think is quite remarkable, quite good. I won't say remarkable because it's what we do, right? But it's certainly increasing her confidence. What I think most people would call confidence there, that she can attain her goals, that she can get to the things that she wants. And that's what behavior analysts, I think, are constantly trying to do, is help people get to that point. And this is a prime. I never like to talk about it. It's not that we're just trying to get rid of bad. It's the replacement of it. It's learning new skills. That's the key to me in really making getting an outcome like this and putting her on her path forward. Really, being able to accomplish a lot more. Go ahead, Grace. I'm sorry.
No, as a behavior analyst, it's easy to say, like, oh yeah, the science works. But when you have a client like this, and you have the great staff to work with, and you see it work. I sent Michelle a number of graphs, but this one really shows the decreasing trends in the behavior. It's really rewarding to see the science work, and it has well with her.
Yeah, and you've really explored this case, and there are lots of different angles that you've looked at it from, and I would suggest, the only thing I would suggest on the graph is maybe implanting some of those physiological variables, just so that we can kind of see, where some of those things might have had some impact. Because then you're able to kind of narrow things down a little bit and kind of put everything in its own perspective, and finally kind of understand everything that goes on with her. And so I think you've done a great job with this case, so I really appreciate it. I'm going to open it up and let anybody who is out there in our audience to come on and ask any questions they may have. Any questions from out there in Clinical Consultation Network land or comments? Michelle is my co-host today. Do you have any questions or comments?
I don't have any questions because I'm pretty familiar with the case from working with Grace, but I do want to say that Grace and the staff at HJC have done a great job at really taking the time to figure Jill out and figure out what works for her and what doesn't work for her. And they've definitely had some obstacles in that, but they've done really well to implement the plan and come up with creative solutions for things for her. And I think that's evident in the data, but I commend them for that and I hope that the transition with her goes smoothly. I know she is very well loved there.
Yeah, it's so true because it's not just stick-to-itiveness that we're trying to help the person develop, but also stick-to-itiveness on the part of the staff. You really have to stick to it to learn these things about someone and to really understand what they're trying to communicate to you, and then how, that's the path, really, to how you can help them. And you guys have illustrated that beautifully here in this case. So I appreciate you guys coming on so much. Josephine came here all the way from Senegal to give us this moment. That's great. And Grace came from Georgia and another person from Louisiana. If you can put those three together, you're going to have a pretty good team. So that is a wonderful thing. Thank you all for being here. Really appreciate it.
Thank you for having us.
Thank you for having us.
Thank you.
And to everybody else, we do this at 1:30 every Tuesday at 1:30 Central Time every Tuesday. So please join us for the Concentration Network. We really appreciate having you here today. And next week, do we know what we have next week, Michelle? Can you recall?
Give me just a second. I can pull it up.
Okay. Michelle's been a fool and I was just kind of sitting here thinking about it. I should have asked her to do that earlier. Didn't get it.
It looks like it's going to be nursing, and we've got a case, a guy that was actually brought to us by a behavior analyst, I believe, who's had a serious decline in functioning with an unknown medical cause. So it looks like Bill and I think David are going to be co-hosting to talk about that fellow.
Yeah, my recollection was that fellow's history was, and he's got a lot of particular interest, but he also had some pretty severe headbanging behavior earlier in his life. And so I think this would be a good case for us to kind of explore what might be going on with him now and think about some different hypotheses and so forth. So I encourage you all to be here for that discussion next week. Who's the presenter? Do we have the presenter listed?
I do not have the presenter listed. I just know that David had been in correspondence. I'm not sure if it's going to be the VA or someone else on the circle.
All right, we'll get that information out there, everybody. But I appreciate you being here. We will do it again next week, 1:30, which place that Michelle just talked about. So please be here if you can. And if you couldn't be here, let everybody know who wasn't here that they can find these recordings on the DIU website under Clinical Services, Clinical Consultation Network. So we appreciate y'all being here, and we'll see you next week.